Hello, online students. Okay, it's week 13, so you should be excited. Woohoo, right? Pat yourself on the back. Good job. Almost there. Hang in there. Y'all hear me say that all the time, and I do mean that. Trying to support y'all and think about y'all all the time and really hope that you make it through this. All right. Without further ado, though, I will be recording childhood infections. When you get ready to study for this content, please, 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 please study what's in the content module. I have posted two fast fact sheets, you don't want to say that too fast, on bacterial infections and rickettsial. So make sure you know them. There's some links in there to YouTubes and some other things. Make sure that you do access them. As far as the viral infections, we're going to be doing those in the discussion board through memory cards, and I will have directions for that. So that leaves childhood infections. There's also some articles to read. Please read those. Very good articles and some handouts to review. All right, so we're going to get started now. All right, childhood infections. Not the best, most exciting material, but a necessity nonetheless. All right, as far as a review question, I want you to go to this link. I can't do it right now. It won't let me, or I would love to. And it says, which of the following stages of Kohlberg's moral development does the following clip best represent? And after you watch it, I want you to pick one of those. And then the next slide will give you the answer and why. So we'll just skip right over that. So let's talk about the principles of infection. We all know the signs and symptoms that's produced by an infection has to have something to do with the interaction. And the interactions among what we call the epidemiological triangle. Now this is covered on page 18 in your Peds book. So right now, if you don't have your Peds book, you need to pause me and go get it. And it shows you a good picture on page 18 of the epidemiological triangle, and it shows you labeled at each corner. And we know that it would be labeled the host, the agent, and the environment. If we're talking about the agent, of course, that is what's causing the disease or the infectious agent. When we talk about the host, we're talking about the what it's invading, whether it be an individual, a group, a community. And when we talk about environmental factors, we're talking about the setting for the host. That can include the climate, the conditions, the socioeconomic factors, the home, the neighborhood, the school. What kind of environment is it set up in? So you do need to read over those. Alrighty, so let's think about it. Does the degree of fever always correlate with the seriousness of the disease? Always means no, usually. So the answer is no. In fact, if you think about two children in the ER, one has 103 fever and you look over, their nose is pouring, they're pulling at their ears, you can probably figure in your brain otitis media, rhinitis, respiratory, maybe upper respiratory infection. I know it's causing that 103 fever. Compared to the child who's in the ER who has 101.5 with no other signs and symptoms. In fact, the one with 101.5 could be in much serious condition than the one with 103. So that's why we have a lot of lumbar punctures done on children with fever of unknown origin, because we want to rule out those more serious things like meningitis, for example. Terminology, and you do need to know this. There is a quiz this week, and this is where I would start on terminology, is knowing some of these terms. Pathogenicity, virulence, sensitivity of the organism to antibiotics. Okay. When we think about pathogenicity, it's simply the organism's ability to cause a disease. Okay, the organism's ability to cause a disease. Not all bacteria, viruses that live in our body are bad for us, unless they migrate to an area that they should not be living. For example, if a female wipes incorrectly and brings stool or E. coli from the rectum into the vaginal area, it could cause a UTI. So normally, though, when it lives back there all by itself, it's doing fine, not causing any problems. So pathogenicity, the ability to cause a disease. Virulence, the ability to invade the tissues of the host and cause a serious illness, and how virulent it is, how serious it is. So test yourself, which of the following is more virulent, rhinovirus or rabies? Of course, you should have picked rabies. All right, let's look at sensitivity of the organisms to antibiotics. We know that there's an increasing number of resistant bacteria. Up to 85% of all of our Staph aureus strains are now penicillin resistant. If that doesn't scare you, it should. So how did we create this monster? Well, part of it is human nature. Well, our child is sick, we go to the doctor, they tell us it's viral, they've had a fever for 3 or 4 days, so we still demand antibiotics. Or we get antibiotics and we don't take but 3 or 4 days worth, the child gets better, so we just forget that other 6 days and we don't take it, and then the child ends up next time being resistant to that, and it takes even more. Because the bug wants to survive just like everybody else, so it's going to mutate itself, and it's going to become resistant to the bactericidal and bacteriostatic effects of those antibiotics. Alrighty, typical course of an infectious agent or illness. There's 5 steps: the initial infection, the incubation period, the prodromal period, the period of communicability, and the resolution of infection. Now, if you look at the definitions here, and I would study these for my quiz, the time interval between exposure of the disease to the appearance of initial symptoms. So incubation period, when I've come into contact with it, I see the initial symptom. Prodromal picks up there the time interval between the early manifestations and symptoms and a time when the overt clinical syndrome is evident. What brings that on that I know that I have this disease? The period of communicability is the period of time during which the infectious agent can be transferred directly or indirectly from the infected person to another person. And then finally, resolution of the infection. So let's talk about an example of Aunt Bert's potato salad. Okay, you're all invited to the annual family reunion. Aunt Bert brings her famous potato salad that morning and leaves it out on the table. Unfortunately, it's a hot day outside. Well, you don't eat till about noon that day, but you love Aunt Bert's potato salad, so you get an extra spoonful. Initial infection. After 1400, so that's the initial infection when you came into first contact with it. About 2 o'clock, you tell someone, you know what, I ain't feeling good. Start rubbing your gut, you're achy. Incubation period, initial symptoms. Well, within the next hour or so, you're vomiting, severe cramps, and diarrhea. Now you know you shouldn't have Aunt Bert's potato salad. Prodromal period, the time when early manifestations and the overt clinical syndrome. The overt clinical syndrome for food poisoning would be the stomach cramps, severe stomach cramps, vomiting, and diarrhea. Now, period of communicability, there is no transfer of food poisoning from person to person, so there is no period of communicability. And within 24 hours, you feel like a new person after Aunt Bert's potato salad has left you. So that would be resolution of the infection. So hopefully that helped make it make a little bit more sense. Of course, we know when we're getting ready to talk about infection, hand washing is our #1 agent to help us with that. We know that fever is also a good thing, and we know that there's a heat regulating mechanism, and it's in the anterior and posterior parts of the hypothalamus. And both of those are very sensitive to temperature that's passing through that area, so that they will know, if it's warm, then you need to break that back down. That you need to stimulate the anterior part, which is the heat losing center. Or it may be that you need to stimulate the posterior part, which is the heat promoting center. So think about it. When you need the heat promoting center, when you need the body to warm up its temperature, then what happens? Well, 4 things. Cutaneous, C-U-T-A-N-E-O-U-S, cutaneous vasoconstriction, #1. So we vasoconstrict. #2, we increase our metabolism. #3, increase muscle tone. And #4, shivering. So those 4 things are going to cause the heat promoting center to kick in when it's stimulated and increase the temperature. So let's think about it. When the heat losing center is stimulated, then don't you think we would see just the opposite? So we would see #1, cutaneous vasodilation, sweating, and #3, decreased metabolism and muscular activities. Decreased metabolism and muscular activities. All right, is laughter the best medicine? Well, you judge for yourself. The average adult laughs 15 times a day. The average child laughs 400 times a day. Laughter, we know, research is supporting of it, that it causes and fosters relaxation, and it decreases cortisol levels. So the moral of the story is people who laugh are healthier and happier people. So you need to just give yourself a laugh break. Terminology, make sure you know this as well for the test. This is covered on page 450 through 451 in your book. We have what's called in our body a set point. And if you think about it, it's just like being in your house. You have in your house a thermometer, and you have it set at about where you want the temperature to stay. Well, we have a thermostat-like mechanism that's located in our hypothalamus, and it stays around a certain core body temperature. But now when it comes into up against certain pyrogenic substances like a bacteria during an infection, that can actually increase the set point or the temperature, which will result in fever, which is also known as pyrexia, an elevation of the body's temperature following a disturbance of the regulatory mechanism. Rectal temps, oral temps, and axillary temps in the book gives you a definition of those. Now, if you'll refer back on page 112, because that was something that we went over when we were asking questions about who wants to be a pediatric growth and development specialist. And we read this nursing alert that said, the belief that core temperature can be estimated by adding 1 degree Celsius to the temperature taken in the axilla is incorrect. Do not add a degree to the finding obtained by taking a temperature by the axillary route. Now they are saying simply add a degree, not simply add, simply write down the route that you took the temperature. So if you took it in the axillary and you've got 100, you do not add a degree. You simply would write 100 degrees Fahrenheit AX, or in the axilla area. Same thing with rectal. We do not subtract a degree from rectal. Okay. It tells you there some recommended temperature screening routes on page 112, box 610. And then it tells you on page 113 and 114, it goes over really good the temperature sites on page 113. And then 114, it gives you some evidence-based practice as far as temperature medicine in the pediatrics. Okay, so you can read over those. All right, hyperpyrexia is temperature that reads or exceeds 104. So once it reaches or exceeds 104, hyperpyrexia. Then when it gets above 105, it becomes high fever. And then when it gets above 107, it becomes harmful fever. Nursing interventions for elevated temperature would be treatment depending upon the elevated temperature, whether it's due to fever, which would be an alteration in that set point or that thermostat-like area, or if it's because of hyperthermia. And that's the body's temperature exceeds the set point, okay? And that would be like someone who is suffering from a heat stroke. So sometimes a child can actually come into the ER and be suffering from not only a fever, but hyperthermia. Let's say the child does have fever. Let's say it's up to about 103, and you go outside into the ER, and they're wrapped in 4 blankets and a onesie that's really, really thick. Then just taking some of that off, those layers will decrease that hyperthermia and that being overdressed. The principal reason we know for treating fever is the release of discomfort, and the most effective intervention is the use of antipyretics. Okay. We know that suppressing fever may actually cause more harm than good, and that's because fever increases the activity of white blood cell production. In fact, studies show that children actually recover a lot faster from some childhood infections, particularly chickenpox and measles, if they're not given any type of antipyretics, such as Tylenol or ibuprofen. Pharmacological management, you need to remember this. Page 163 in your book has a chart that goes over some of these. Tylenol can be used for children of all ages, acetaminophen. We know it has antipyretic analgesics, but no anti-inflammatory effects. And it's the drug of choice for fever in children, even though the newer studies are saying that ibuprofen may be a better drug of choice. It's available in suppository, liquid, drops, and chewable forms, which makes it kind of a scary thing because people have overdosed children on Tylenol because they did not follow the manufacturer's labeling on dosing because they didn't realize it was the liquid instead of the drops or vice versa. The norms is 10 to 15 milligrams per kilogram every 4 hours. Okay. Common side effects would be anything from abdominal pain, drowsiness, hepatotoxicity, rash. It can mess with the hematological alterations as well in the lab report. So we don't think about Tylenol causing a lot of problems, but in actuality, it does have some side effects you need to be aware of. We know the onset's anywhere from 30 minutes to an hour. It peaks in 1 to 3, and it lasts up to 4 hours. That's why we can give it every 4 hours. Ibuprofen, we know, is approved for children as young as 6 months. And remember, the division on that is on the temperature. Your book says 102.6 in this chapter, so we'll just go with that every 6 to 8 hours. If 102.5, I'm not going to get that picky and ask that close. But if it's less than 102.5 to 6, we're going to give 5 milligrams per kilogram. Above that, we're going to give 10 milligrams per kilogram. And for pain, 10 milligrams per kilogram. It has all three of the things we're looking for, antipyretic, analgesic, as well as anti-inflammatory. Now, it can be given alternately with Tylenol, but I want to tell you to be careful doing that. If you've ever been a parent who's had a child who's been very, very sick, it is very easy to be writing things down and to get off track and not understand and not to be able to write those down. And then before you know it, you've given 2 doses of Tylenol in a row instead of alternating Tylenol and ibuprofen. Every 3 hours you actually give 2 doses of Tylenol, and then that was too close together, and you can cause some effects. You want to make sure if a parent is doing that they're writing down in a journal or on a piece of paper or something which one they gave last, because when you're that tired, you forget. Also, the metabolites in the presence of dehydration, ibuprofen can cause some kidney damage, as some studies have also shown. Aspirin is not recommended for children under 12 because of its association with Reye syndrome, especially in the presence of viral infections, particularly influenza and chickenpox. But it does have the antipyretic, analgesics, and anti-inflammatories, but we just usually don't give it. All right, so environmental measures, and these are only done if they can be tolerated and they don't induce shivering. Why? Because we just talked about shivering. Shivering is one of the things that happens when you are in the heat promoting center, and we're not wanting to promote even more temperature increase. So minimal clothing, exposure of the skin to air, again, only if it doesn't induce shivering, reducing room temperature, increasing air circulation. Cool, moist compresses, again, if it doesn't induce shivering. A lot of people are using lukewarm now. And tepid baths and sponging, again, as long as they don't induce shivering, so lukewarm. Never ever use alcohol, and this is one of those really never evers. And that's the rubbing alcohol. And the reason why, number one, the fumes can be toxic. And if you think about just taking a little bit of alcohol and wiping it, sometimes it takes your breath away, let alone trying to do that on a whole body. The rapid drop in temperature causes vasoconstriction. Well, vasoconstriction causes increase in the thermal and the heat promoting center. So don't be surprised if the temperature don't come back even higher. Another reason is because it's absorbed through the skin, and that can lead to neurotoxic effects, such as stupor, coma, and death. And lastly, it dries the skin out. Febrile seizures. Febrile seizures are the most frequently occurring seizure crisis affecting children. About 5% of all children will present with some type of convulsions when they experience a high fever. No one can be certain which child will exhibit convulsions with fever until it happens, but once a febrile convulsion is present in a child, they will be prone to have other similar episodes. Now, just some myths versus facts, and you can tell me which one you think it is. The statement is, a child needs a full neurological workup after every febrile seizure. And that is a myth. In fact, they do not need a full neurological workup after every febrile seizure. And some children can have more than one a day. You would be doing that constantly. Febrile seizures have no genetic basis, myth or fact. And that is a myth. A child whose sibling has a febrile seizure has a 10 to 20% chance that they'll also have one. Another statement, a child who has a febrile seizure will have one with every future fever. And that is a myth. The fact is not necessarily. It depends upon the age, and we'll talk about that in a little bit. Myth or fact, a febrile seizure is the earliest indicator that a child will develop epilepsy. And that is a myth. Less than 5% of children who have a febrile seizure develop epilepsy. And the last statement is there's no danger of febrile seizures causing brain damage. And the fact is that febrile seizures don't cause brain damage, decrease IQ, learning and mental disabilities, or cause death. Now, there may be an underlying disorder with that causes it, that's a culprit, but not the febrile seizure. All right, so now that we know a little bit better understanding of febrile seizures, let's talk about the age at which the febrile seizure does occur between the ages of 3 months and 4 years. Sometimes as young as 3 months, maybe up to 5 to 6 years. One of the things that you need to keep in mind is this is the tonic-clonic type. There's not much in your book on febrile seizures. There's a little blurb on, I believe it's 651. It talks a little bit about febrile seizures, and then I believe on 9, let me look here, make sure I've got my pages right. 966. 966 has a blurb too. And again, the nursing alert on 966 says that if a febrile seizure lasts more than 5 minutes, parents should seek medical attention right away. Parents should call for emergency assistance and not place the child who is actively having a seizure in a car. Right. When we're talking about febrile seizures, again, we're talking about 3 variables that play a role in the path, though. We're talking about the presence of a rapid increase in fever, that they are usually at a young age, and 3, genetic predisposition. So the 3 main variables in the path of febrile seizures are those 3 things. Presence of a rapid increase in fever, young age, and genetic predisposition. What causes this? Well, the illnesses cause when the fever goes up. And again, it's that rapid increase in fever. It's not the kid that's had a fever starting out at 99 and it's slowly inching its way up over a couple of days up to 104. It's the kid who wakes up and has 104 fever. Viral infections are our most common cause, as well as respiratory tract. Now, some children have a tendency to convulse when they have high fevers, others do not. And they think it's related to the immaturity in the brain, which is related to a deficiency in what we call GABA, which is gamma-aminobutyric acid. And the role that this plays is that it's an inhibitory neurotransmitter. And its function and activity is not usually stabilized until the child reaches 4. So after they reach 4 and this GABA has matured, that's why they say that you quit seeing these febrile seizures after that time. One of the parents' first questions may be, is my child going to convulse again? Well, the answer is depends. And it depends on the age of the child. If it's a child less than 1, they actually have a 50% chance of it reoccurring. If they're between 1 and 3, a 30%, and over 3, 15%. So you can see that it decreases with age. Some, as far as treatment, that's controversial. We have some who won't do anything with febrile seizures. We'll have some that do treat it because they're having frequent seizures. And then we'll have others that only treat when the seizure is present. So it just varies. One of the main meds we give is phenobarb, Dilan, of course, Valium, if it persists greater than 10 minutes. Again, at about age 4, they start decreasing these if they do put them on there because the EEG findings until they become normal. And with the GABA maturing at about that age, we do find that if it was abnormal, it may convert. Here's our dosage of phenobarb. You do not have to know that for test purposes. Do remember that it causes drowsiness, lethargy, rashes. It suppresses REM sleep, so it's not without side effects. The good news, though, is that febrile seizures, they are the most benign, and they're the easiest to control, and that they do cause little sequelae. All right, one of the things I want you to do, if you don't know what bile debridement therapy is, or MDT, which stands for maggot debridement therapy, I want you to Google that and watch some YouTube videos on maggot debridement therapy. They're using maggots more and more in wounds to heal them. So that's one of the things you'll hear a lot about. When you're taking the test, some of the things you can do is avoid doing the old what if, or what if, but what if, but what if. Don't what if, just whatever the question states, do. Focus on the information in the question and look at what it's actually asking in the stem. Look for strategic words, always, none, never. Always use the process of elimination when choices or options are presented. And then once you get it down to 2, go back and reread the question and make sure you understand what it was asking. Determine if it's a positive or negative response. Is it asking which of the following questions would you shows that the patient indicates understanding of teaching, or is it asking you which of the following statements indicates that further teaching is needed? That's a lot different. Focus on what was stated in class or given to you in class. If it's an option that we haven't talked about at all, chances are that's not the correct answer. Just a little review. Secondary screenings. So any type of screenings you see on your test, that would be the level of prevention screening. Primary is anything that helps that you do before to try to prevent something from occurring. Immunizations are primary. And then tertiary is once the disease has occurred and what you're doing to help with that process. The anterior versus posterior fontanelles. The anterior closes when? The anterior is the larger one by 12 to 18 months and the posterior by 6 to 8 weeks. And don't forget to review your normal ABG levels. I might throw 1 or 2 in there just to keep you on your toes. In case you've forgotten, pH 7.35, 7.45, CO2 35 to 45, and bicarb 22 to 26. All right, thank you, and that will conclude this part. Have a great day, and let me know if you have any questions or concerns. I would tell you to please go and look at your handout that I gave you over types of immunity, natural versus artificial. If you go in there and you download that handout, you'll see I gave it to you in pictorial form to help you know it a little bit better. Naturally active is when you contract the disease yourself so that you produce memory cells. So you go in and you have to sleep with your cousin who has measles because your mom wants you to get measles at the same time. Then you just have acquired that naturally actively because you come into contact with it and your body developed antibodies. Artificially active, on the other hand, is when you receive a vaccination that produces memory cells. So instead of getting the measles, you got the MMR and you develop memory cells. That would be artificially because your body didn't develop the antibodies by coming into contact with it. You were given the actual vaccination artificially. Then you have the passive natural, and that's when you receive maternal antibodies through the placenta or breast milk. It is passive because it's given to the baby, but it's by natural means. And last but not least, you have artificially passive, and that's when you receive antiserum, antivenom antibodies from another host through usually some type of infusion. Those type questions will be on there. Please make sure that you know them. Alrighty, that concludes this part. Thank you.